Welcome to the University of Michigan Dentistry Podcast Series, promoting oral health care worldwide.
And we've got an R and 3 S's. Let's see, we're going to get a little better light here. I don't know, you left-handed? No. Okay, let's get this straightened out a little bit. Get it over to your light. If you get too far in your light, you're in trouble because these lights don't throw that much for you. Now you can see what you're doing. Now you're going to blind me though. Okay, and you added an R for surface, and I'll agree with you. It's a nice shine. Okay. Margin integrity. I kind of agree with you on that. What's the difference? It catches
on the buckle
there, going from where to where?
From two-tooth, right? Yeah.
More two-tooth,
right.
but
I used a greenstone on that
Yeah.
to try and take care of that, but maybe I didn't go quite far enough.
try that yourself right in that area. I want you to feel it. It goes two-tooth mainly, but it also goes from tooth to amalgam a little bit, doesn't it? About half as much to amalgam as it does
Probably
to
only
tooth.
took care of the greenstone on half the surface I was working.
Well, when you get a little lighter touch, okay? Now look how white your fingers are. That Explorer is kind of like your phonograph needle on a record. You don't take 10 pennies on the arm and get any tone quality out of it, okay? Same way here. Lighten that up and go across that lightly and keep it perpendicular. And now I can feel it catch coming back, okay?
Yeah.
And you can feel it catch more going out, okay? And that's the type of touch you want there, okay? Now, if it touches in both directions, what does that mean you got?
It touches in both directions?
In other words, can you draw your margin in there? Okay, this is your margin. If we blow that up, can you draw what you got there?
Like this. The dip? Is that what you said?
Right. You got a trench. Okay. In your case, if this is tooth, most side of the tooth is a little higher than the amalgam. Okay. So you're catching more going that way than this way. If you're going to dress that, what are you going to use on it?
This? The greenstone on the tooth?
Greenstone, maybe a white stone. Okay, that may be the thing. You may have had the greenstone on. The greenstone is so rough that it's chipping it out.
Do we have white stones?
I don't know. Maybe you don't yet.
We do.
Okay. Well, you will next year. But that's the thing. Your greenstone may be so coarse that it's giving you this, and it's not not below an S, but it is an S. But that's what you're feeling across there. Okay. Anatomy. If you didn't crowd your marginal ridge at the distal, I'd have gone to an R. Okay. But you see what? You had it at an S, but that's the reason. Your center groove comes through nicely, but your distal fit is too close to your marginal ridge, and you got a little thin marginal ridge.
Yeah.
And then contour, proximal contact. You're reaching for contact is what it amounts to.
Right.
And so there's not much you can do with that. It gives you an odd contour. If you stay in S, which is still a good solid contact, you've got the contact, but it just doesn't have that curve. And when you mount your practical, make sure you got it mounted back so you're not having to reach for that contact. Okay, that's a nice practical. This one you're going to pack for the practical?
I cut that over this weekend. I just wanted to get your opinion on it and what you... I think I overextended it a little to the lingual.
Yeah, agree with that. It's...
But I tried. I've been like semi-cutting my axial wall deep all this whole time, so I thought I tried to get that.
This might be a little conservative right in that area.
Yeah, right at the point.
See,
I thought about that.
Yeah, the idea is you want to get your Explorer in to feel that margin later on, and you see I can't do it. Okay? I can down below, but when I get to the top, I wouldn't be able to feel it right in that little corner, okay? Now that means you maybe today better extend that out because this is the one you're going to pack, and they're going to say, well, you know, that you can't evaluate that, okay? Dovetail looks pretty nice. We look good across there. Pulpit floor depth is good. Axial wall's a little flat. Doesn't have the curve, but you look good that way.
Usually I end up with a concavity, so that's better than usual.
Yeah. Little scarring in the adjacent tooth. Do you feel that?
Yeah.
Polish that up beforehand or your contact is going to feel rough.
Okay.
And that may be done with a hand instrument rather than a burr, because realize you've got sharp edges on your hand instruments. Not only the end, but the edge is sharp. And if you're not judicious going up and down, you'll scar that tooth, especially on melamine. And you can scar not so much enamel, but you can scar amalgam with that rather nastily with a hand instrument. Okay? All right. So let's, if you flare that, can you do it with just flare?
Can I do that with just flare? Do what with just flare?
Clear that buckle extension.
I kind of doubt it.
No, you're going to have to extend that whole buckle wall a little bit or you're going to be out too thin.
Yeah.
Okay? All right. Good enough. Okay. So let me see that after you get that buckle. Okay.
Okay. Tooth 24, what do you have for diagnosis?
We have pulpal necrosis as the diagnosis.
Okay.
Negative on EPT and all hot and cold and percussive tests.
Okay, did you do tests on the other teeth beside it?
Yes, I did.
Okay, so you found that 23 is positive to cold, and so is that one.
Right. Although I did
How about
get
EPT?
I did get a negative on 23 to EPT for
Wouldn't you
some
want to
reason.
run that again and find out why there's that problem?
I ran it several times, and the first one I know it was the EPT tester, and I got another one. And
Okay, when anytime you have a discrepancy here, go and test the new tooth next to it also and find out, especially when you've got a radiolucency here that incorporates two teeth. Okay, I would definitely, we do need to do a root canal on that one, but I think, definitely would want to test that particular tooth and find out why there's this discrepancy. Now, if
that
you...
was a definite on the thermal test. That's why I didn't go back to the EPT.
Okay, do you have 2 cotton rolls and an ice stick for me that I can have? You don't have the ice right now because it's melted. Okay, so if you've got 2 ice sticks, if you've got 2 cotton rolls, where do you keep those?
Besides the ones that came in a little kit.
Do you have 2 in here?
I've used them for doing my thermal testing.
Okay, I just want to show you how I do it, and I think you probably have gotten a false positive. Okay? I use 2 cotton rolls. Okay, open real big, that away. One is placed down here, like that. The other one, with my finger, goes right like that underneath the tooth. Okay, then you bring the ice stick in and put it right at the cervical area. What does all this cotton do? This keeps any runoff from going anywhere. This one does too. The problem is that if you've got cold, it's a big ice stick, right? And if it runs to the side, where's it going to go? It's going to go to the tooth next to it, and it may give you a false positive. The other thing you need to do is let him know the difference between what the dead tooth feels like on the gum and the one next to it. You don't want response from the gum.
Right, he distinguished clearly.
Well, he did do that, okay, but still there could be some flow off. So why don't you get some ice, and let's try that right now, and verify that before we go on. Because if you're going to do 2 root canals, why not do them at the same time when you can use 1 set of x-rays for 2 teeth and we can cut down on the radiation?
True. Okay.
Okay? Let's try that. We'll be back in just a minute, okay? Which kind of ice stick do you have there?
Needle hole.
Okay, good. That's the kind I like to use. I don't like to use the other kind. We have the cotton still? Okay. All right. Put this up again. Okay, and the ice. That's good. Okay, tell me when you feel this. Now I go right to each tooth. Okay. Feel that?
Uh-huh.
Okay. How about this?
Uh-huh.
Okay. How about this?
Uh-uh.
Okay. And how about this? Okay? Now the one that we've questioned is this one. And you can't really get at it real well, so I'm going to come in behind. Feel that? Okay. All right. I would agree with you. Now the question is, why didn't your EPT read? Okay, so let's redo the EPT now.
Okay.
So why don't you hook that up real quick? Now some patients will respond to the buzzer only. I had a patient do that. I had to bring him back in another time and redo all the tests and said, now tell me when you feel a shock. And the person said, oh, I was responding to the buzzer yesterday. So you got to be careful on that kind of thing. You've got some toothpaste? Yes, please. He's going to go get some toothpaste and we'll be right back with you, okay?
Yeah.
To start number 11, do I have to take the cavity out before I start prepping it?
No, I'd rough prep it. Let's
With the cavity in?
yeah, let's just rough prepare it and see what we have available there, okay? And then that'll give us a little better idea of what we can get by with as far as, saving tooth structure.
Okay.
All right?
Sounds good.
Did your young lady desert you?
Yeah, she wants to pour out that impression.
Well, I guess I could do something constructive. Haven't done this in a long time, but
All right. I need to put another burr in too.
Put on my safety glasses and we'll be all set. Beg your pardon?
I'm going to need a rough diamond or a 171 L to start rough preparing this. Make sure she has one in there.
Well, I said I'd suction the water. I mean,
So you say you change
I didn't say I'd change birth water. I mean,
I think that's the guy she's using it too.
Yeah, that's what it fits in. Where do you want me to go?
Good disco.
Okay. How's that?
Oh, that's fine right there. I'm just going to take down a little bit.
I kind of like to try to keep, all the material in the tooth, so then when I get done, why, then I can take it all out.
Right.
But at least I don't lose sight of what I'd like the end product to be.
Right.
Okay.
I understand what you're saying. So look for me this spot. Look at all the clay over here.
Come on. Oh, we're dripping?
Yeah, a little bit.
All right. Here, just... Cut yourself some tracer cuts first, so cut some tracer cuts on there so that you know how much reduction you got. Okay? Sure. Hey, if you don't have a plastic shell, it's awfully difficult to know when you're done whether or not you got adequate amount of reduction.
Right.
If you're going to reposition the tooth, then it's very helpful to have, a wax up and one of those acrylic shells, because then you can slip the acrylic shell over the top of the preparation, and then it represents what the final restoration is going to be, and then you can get a pretty good idea of how much reduction you have. Because sometimes it's not necessary to take that full millimeter and a half. You know.
Right. Yeah, like here, look at.
As you can see how much time you waste with a dull burr.
Oh boy.
You know. And in your office, the only time you're making any kind of money is when you're at chairside.
Right. Hello to me. Thank you.
So that's when you want to be most efficient.
We're slipping in there.
And we didn't do a very good job.
No, yeah. Need to tighten a little bit more.
You got something else we could use for reduction besides that, so we're not here forever and ever? How about this little rascal right
You
there?
gotta do a good job.
You want this? I grounded you. Sorry about that.
Look. I didn't get loose enough.
No, you didn't.
She's not there, this thing we are.
Okay. And I gotta get in there, pal. Okay. Just raise your hand and we'll stop for a minute.
This all it is decay and old composite.
A little smaller than what you got there. Maybe that'd be a little better to get in approximately with.
We can just put that one on this one if you want.
Yeah, that's a good idea. This is this one. You play hygienist for him, assistant for a minute. Let me sit down there and
Okay.
work that little rascal over for a minute, would you?
A lot different being this high up.
Beg pardon?
A lot different when you're this high up.
Yeah, turn your head towards me, please, ma'am. No, a little bit further even. Fantastic. How come? Wait a minute.
I thought they switched automatically.
So do I. Maybe that isn't all the way back or something. There we go. Okay. Get a little bit of this in here so we don't... the burr out a little bit further. Trim a little off this inside the ledge right now.
Pardon?
I'm going to trim a little bit off this inside the ledge so we can
We
reach,
take it off anyway, so it's
reach down a little bit further. I'll just back this burr out just a little bit further. No, that's not it. Girls must be getting their pictures taken for the yearbook today or something.
Yeah, we're doing.
Okay. Alrighty. Beautiful. Great. touch it. To get a shoulder in there. Mirror here so we can see what we got on the lingual. We're rounding her again. Yeah. Oh, here's our girl. Here's our girl. Help. Jerry, could you help us out for just a minute, please? I just want to break this contact and then he can do most of the rest himself. Let's get this over here so we don't get your blouse all wet. Just don't want to drown her, that's all. Thank you. I just want to break this contact on the distal for you, that's all. And I'll let you do the rest yourself. Now, before we take the impression, we'll want to go back over that amalgam in the bicuspid with a sandpaper disc because I probably hit it a little bit. You got to stay open a little bit more for me, please.
Well, I think then what I would suggest is I think her plaque control is very adequate. Her attached gingiva is bordering on being inadequate here. Okay. Right? Okay, I'll be there. Just. Okay, now.
You're still L62, you're still L62.
Mucogingival junction.
Mm-hmm.
Here?
The mucogingival junction?
Mm-hmm.
Down lower, I'd say.
Where? Here?
No, lower yet. Right down.
Show me where you think it is.
Mucogingival junction, I call that this area here.
Good. We need to talk about that.
Okay.
Because it is here.
Okay.
Okay, and let me tell you why you get fooled. When I do that, notice where it comes up to.
I see all the way. Okay, right.
Okay? Now the other trick to do is to take your and sort of roll it up. And notice it rolls up to right about here.
Okay.
A third thing is look at the blood vessels. Where do the blood vessels
They go up to the mucogingival junction.
Okay. And notice there's a little frenum here.
Mm-hmm.
So she has minimal attached gingiva.
Okay.
Right? Okay, what do? We measure the outside, that's 2 millimeters. You measure the inside, that's about 1.5 millimeters, so she has about 1 millimeter of attachment. Why do we bring this up to her? She's got to stay on soft brush and the short rotary stroke, never back and forth, or she's going to destroy all of her gum.
Okay.
Right? Which, so,
Now, you from a back and forth. I mean, from back and forth brushing motion, you're going to just wipe a destroy part.
yes,
I don't
see,
quite
the
understand that.
gingiva across those roots are like tissue paper.
Okay.
Now, and there's probably dehiscences. Okay, there's probably not bone on those roots. If I were to take and reflect the gum off that tooth, you would probably find bone right about
That
there.
level. Okay. So where she's brushing it on a higher
There's
level.
unsupported gingiva.
Okay, I see.
And she does this. She's not, but if she ever does this, she's going to wipe it right off.
Okay.
Because so your area of concern then would be these lower anteriors,
Okay.
because of minimal attached gingiva, distal number 17,
From a pseudopocketing standpoint, cleansing of the bridge, especially around the distal abutment, and the frenum here. Now the question is, what do you want to do about these things? Here, make sure her brushing's okay. Here, possibly do some therapy.
Would that be gingivoplasty?
That's right.
Okay.
That's right. Here, do a frenectomy when she so desires. And in here, re-emphasis with something additional aid, either the Norwegian stimulators or the rubber tip stimulator or something of that nature.
And that's just tracing the margins of the gingiva?
That's right.
Okay, fine.
That's right. So she's in very good gingival health, though. Good. You're doing real good on ply control. Real well. I would have put her ply control a little lower.
Would you
like me to go and stain her?
No, because if she had some real significant deposits, I would.
Okay.
But I would have put her ply control somewhere around 15%, with areas of concern being your bridge area.
Those two areas are of concern, particularly in quadrant 4.
Okay. So if you will write that up, what we were talking about, some additional therapy would be back here on the very back part of that tooth. We call that a gingivoplasty. Plasty, I'm sure you're in your profession, you can relate to that. Essentially, you have more gum than you need, and it's not attached to the tooth. So it is a pocket where there's plaque, food debris that's getting down in that area. What we would like to do is give you just not today, but at another time, give you just a little bit of local anesthetic, a little numbing, and then essentially just remove that 3 or 4 millimeters of that area so you can cleanse it. And I think that would stop those problems. Okay. So once you write that up, and then we'll talk to her about that.
Open the move already.
What do you need?
Okay, tooth 11, which I'm working on the class 3 amalgam, is a little rotated, or not in itself, but relative to the adjacent bicuspid. And I'm just a little confused the angulation. I know that this there's a little enamel that I'd like to take away. It's right, adjacent towards the lingual, but adjacent to the bicuspid. But to get in there and get the angulation, to get it away, like to thin, I can't see how you can get in there and just thin the way you normally would and then break it away because of the angulation.
Do it Romberg.
Just kind of angle in sideways. Okay, I was just a little concerned about fitting the adjacent tooth.
That's why I do it with Romberg. And if you're really that concerned, put a matrix in.
Okay.
And also what you have right now in the distal, you've got cervical floor direction is really nice. I know you're not done.
No, right. Yeah, the buckle I would like to flare out a little. The buckle, the incisal, I would like. Yeah.
Right. Okay.
Yeah, I would like to.
So I think if you do this with a rounder, again, keeping these areas perpendicular, I think that'll save some of your problem. What you're worried about is going with a straight fissure and nicking your bias.
Right.
Okay. I think if you did it with a round and did that, you'd be set. And it is slightly rotated, so it's going to cause some problem. If you're that concerned about touching the body, get a piece of that stainless steel matrix and just slide it in.
Okay.
And then go ahead and finish the preparation. And that should take care of it. Because the only way you can do it now is to touch the body.
Okay, now what about the remaining enamel? The enamel that's remaining right adjacent to the body. This will take care of the that lingual angle.
Okay, here's your contact with the bite, and you're sort of concerned about this type. You want to open that out, and you're worried about here, looking down from the...
Yeah.
I'd put your matrix in.
Okay, and then just...
And that'll help protect it, and then... This is interesting one. Why'd you do this? Quiet. And then go in with hand instruments also.
Right.
Try the round bird. You're going to reduce it with your round bird, and then at the end just go in with your hand instrument. And I think that'll cover it right down for you.
Okay, now it's not mandatory that I break contact?
No.
Okay.
But,
I do have to go up a little more in size and then,
yeah,
just to get the...
I wouldn't carry it out all that way, because by the time you break that contact, naturally it's going to be into a class 4 situation.
Mm-hmm.
I would rather not do that at this time. Okay.
Okay,
Do
thank
it.
you.
Okay, good.
That tooth isn't sensitive. I tested it, I took the probe, and I went to the tooth in front of it, and all I did is I rubbed it on the buccal surface on the enamel, and she says that's what hurts.
Okay, then I would infiltrate a little bit on that too. What is it, root sensitivity from toothbrush abrasion?
No.
What do you think it is on the first tooth?
I'm not sure.
Well, let's go and find out. Okay, now there are caries.
Feel that?
See, she does have caries in the distal of 26, okay? We do have caries there. So she may be getting some sensitivity from there, possibly. Or another thing, wherever you have big amalgams, look for fractured tooth syndrome. First and second molars are teeth you should always be suspicious of, especially if the margins are kind of corroded. It might have meant that there was some expansion. Okay. Let's turn this noise off. Good. Anytime you don't need that, turn it off, okay? You'll all be more sane. Let me know where you feel sensitivity, okay? Right there? See, she's got caries there, and she must be picking up some sensitivity off of there, right there.
When I infiltrated the distal, you could say the interproximal. That's a landmark for that.
Do you have any more of the carpio left? No. Because in her situation, if that's where the sensitivity is, then we need to come up and infiltrate as if we were going to be treating 26 to rule that out, which means we'd have to go to pick up that middle superior, wouldn't we?
But usually the middle superior doesn't come to the distal of the...
No, but we've
though.
blocked off some of that. She's got to be picking up somewhere, unless she just has some really aberrant innervations. You should possibly be able then to work 27. Just don't touch 26.
Right.
You might want to put some copalite. Try some copalite along the distal and seal off the enamel rods. See what that does, okay? But otherwise, you should be able to go ahead, do that, and then come back and work the distal, okay? Go ahead and remove the caries. You got all the caries out at the gingival?
I didn't work on the distal yet.
Okay,
I'm
use
still
your...
trying to refine my box.
Right.
On my mesial.
Right.
I've got to come more buccal and lingual.
Yeah, you've got to get a little bit more clearance. And a little bit further gingivally, too.
Right.
Go ahead, copalite, excavate out at the gingival, at the distal, then come back and work the mesial, because if for some reason we're going to be delayed much longer, you may have to keep an eye on your time. We might want to keep those distal walls where we've got them to help hold the temporary in. We don't want to rush an amalgam and not get a real nice result. Okay, copalite, okay, because we've gone pretty well here.
Yeah.
Copalite, excavate at the gingival so we know what our caries situation is. Then go back up to the mesial, and I'd work low speed without the water spray. See how that works.
On the mesial?
On the mesial, okay? Low speed, maybe even hand instrument it and see how that works to decrease the chance of sensitivity.
Okay.
And then just let me know, we'll monitor. Okay? We'd like to get that restored today if we
I'd
could.
like to also.
Save her another appointment. But we want to be comfortable too.
You all right?
No.
That hurt? See, I was just on that surface enamel, too. Which is really strange. But
It's almost like galvanism.
But I can go in here and
no problem.
And hit Denton. And
what I would do when you're working on teeth in that quadrant, I would just almost do a complete quadrant block and get everything. It's the only way, yeah, for her. Until we can find out why that, is occurring.
Now I can see if I was hitting that amalgam, that might be the galvanic part there, but golly, I'm just, how's that? Is that not strange?
Sure is. I can't figure that out either. Is it really uncomfortable or is it just annoying?
I understand it.
Can't stand it?
I understand.
You can feel it. Is it sharp? Real sharp?
Yeah, I get it. That was the part that you just did.
Let me see how far you are in your prep. Because we might do is just go ahead, IRM it one more time, and then the next time you come in, and we'll just start like from canine and do the buys in terms of our infiltration, and do 26, get that completely taken care of. And then you're just going to have to, almost do full quadrant blocks to work on those teeth, okay? Because we don't want it to be uncomfortable because it prevents you from doing a nice job, and then it's no fun for your patient either. So I'd excavate as much as caries you can at the distal, put Dical in, and then put some IR in.
Check my distal, I believe I...
Okay. Because we've given enough anesthesia today.
I've given you quite a bit anesthesia. We just don't want to...
We'd give you more, but for this procedure, it wouldn't be practical to give you a lot more because you'd be numb for a couple hours and you'd be sore, and you're better off just to go ahead and seal this up, and the next time come in, do 26 and get that completely taken care of, and see what happens there. Have your teeth been sensitive at all when you've been biting during the past couple weeks? Have you felt like these have been sensitive? You've been under a lot of strain? Or you've been grinding your teeth at all?
Oh, I know.
No?
Lisa, how's your sinusitis been? Have you had any recurrence to that?
Is it grinding right now?
She I had her
bouts?
ODC one time, it comes in spurts. She had percussion sensitivity to all her, I look at them and try, I can't recall what side it was, but her posterior maxillary teeth were all percussion sensitivity, and we diagnosed it as a sinusitis.
That's probably what is, because in terms of dental-oriented pain, this would not be typical, so it must be some type of a sinus thing that is affecting all the periapical membranes.
Right.
And I think that could be it.
That's characteristic of sinusitis, to have pain, or at least percussion, of all those.
All the teeth. So the thing to do is when you all are working, if she's having one of those flare-ups, I wouldn't do any dentistry in the maxillary quadrants because you'll probably have the same problem. So that's something maybe we factored out of this today, that if you have those problems and he has an appointment for you, just tell him, no, my sinuses are acting up and we won't do any restorative work.
Penicillin, and it cleared her up in her teeth, and she said her sensitivity of her teeth got better.
Right.
So that's
okay. That's probably what we've got then. Right. That'll make it more efficient for everybody then, and you won't have to be uncomfortable. Okay. How frequently do they come? Or do they just vary? Right. Well, that's what I would monitor and check with her then. Like when you do these other ones, make sure maybe call her like the week before, and then make the appointment the night before. Communicate somehow on how it's going.
You feel a pain in your cheeks? You ever get pain in your cheeks?
Not
Puffiness or? Okay, well, we'll work that way.
Or if she has an appointment and you don't want to break it, you can maybe come in and do something on the mandibular area.
Yeah, getting appointments is
right. Okay. All right. Well, at least we found out
on the
pretty much what it is then. Because the lesions radiographically were not that deep that would warrant that type of discomfort for. That feels pretty good, Barry. Let me have a spoon excavator and we'll try this. See, anytime you get any pressure on those teeth, you can see just by her eyelids. See? You can tell without any verbal or nonverbal communication that she would rather be at the beach.
Well, watch my eyelids.
You can be convinced very easily.
Maybe we should perform this dentistry on the beach.
Right. Okay, that feels pretty good. Dry, Di-Cal, and IRM again.
Let me ask you this. I won this life in our ASTA.
Life is fine.
Can I go ahead and say? I would like to try it. I know that, is that just...
Same as Di-Cal, except that the working properties are a little bit better.
I thought also you don't get that layer, that mummified void layer, you know what I'm saying, between the reparative and the effective dentin.
Okay, why would this be different? It's calcium hydroxide, you'll still have a very basic solution which will cause a certain amount of mummification.
And I had thought in the reading that when they made distinction between life, Di-Cal, and there was two others that we read about.
Pulp dent?
I can't recall, but the main thing I remember is they always talk about the amount of mummification that you got.
Di-Cal meaning, okay, Di-Cal being a little bit more basic and causing a little bit more mummification. I think they made a distinction there that Di-Cal might be better if you really, really wanted to make deep secondary dentin. Is that the way it was predicated?
I'm going to have to go back
because there's multiple articles on it.
Yeah, I'm going to go back and find out exactly what they were referring to. But they were referring to when you put the Di-Cal on, you get a reparative dentin. I forget what void they were talking about, or the mummified.
You get a certain amount of phagocytosis after the mummification.
I'll go back,
because they're both chemically similar, except these have a little bit better plasticizers to make it set up a little bit quicker, and it has a little bit harder coating to it than Di-Cal. Okay, well, work with it and see what you think in terms of the handling characteristics, okay? Okay. Patient has a sinus condition. Every time her sinuses are flared up, her teeth just ache. So he was working on 27. No, when they flare up. We're working on 27 today, infiltrated, and all you have to do is move an instrument over and touch on 26. And she'd jump and jump. So we infiltrated even around there a little bit. And anytime he touches those teeth, puts any pressure, she has a little flare up. So what he has to do is whenever she has a flare-up like that, make sure that he works on a mandibular tooth or waits until it's over with. Otherwise, it's going to be counterproductive and uncomfortable.
You've been listening to a presentation from the University of Michigan School of Dentistry, which is dedicated to supporting open learning and open educational resources. This recording is licensed under the Creative Commons. It may be reused and redistributed for nonprofit use. Please attribute materials to the University of Michigan School of Dentistry and redistribute under this same license. For more information on how this and other University of Michigan School of Dentistry recordings may be used, visit www.dent.umich.edu/license.